Welcome everyone. And after we heard Dr. Akhilesh Gupta and Nawin Sona, Akhilesh Gupta ji gave a perspective from the central government angle, from the funding agency angle, and Nawin Sona ji has given a perspective from a state government perspective and a state government angle, and he talked about medical procurement authority and various other initiatives with the government of Maharashtra is taking up. So. Let me request our panelists on the dais. We have with us Madan Gopalji, who is the advisor of the Public Health Administration, National Health System Resource Center, Ministry of Health. And we have Urvashi Prasadji, who is the director of Office of Vice Chairman, NITI Aayog. And we have Vikram Pagaria ji, who is a joint director of coordination between private integration and capacity building cell in the ABDM, which is the part of NHA, National Health Authority. So let me request Urvashi Prasad, who is a director at the NITI Aayog, to speak about the panel discussion topic is shaping the future of healthcare, the interplay of economics and government policies. So how is she looking at the evolution of the healthcare ecosystem in India and the innovations which are happening, and how can government and the private sector collaborate with each other, and what are the priorities of the government itself? So Urvashi, over to you.
Thank you. So I think a lot of ground has already been covered in the two keynote addresses. So I'll just highlight a few important points from the policy perspective, and I'm sure Dr. Madan and other panelists will add to that. So I think the most important thing from an overall health system perspective for India is to build a strong public health system. Historically, we have been a very cure-focused health system, a sort of hospital-based health system. And that is not the route that we can go down. If we're talking of economics, and on this panel, we're talking of interplay of, economics with the health system. It's simply not, economically feasible also to push everybody into a hospital. We have such a large population. Our effort has to be to try and keep as many people as healthy as possible for as long as possible. So that is what is the goal of public health, and we have to focus very strongly on that. And if you see over the last few years, the government has consciously tried to reorient the health system to focus on public and primary health care. A very major initiative of the government in this regard has been the health and wellness centers. We talk about Ayushman Bharat, we always talk about the insurance scheme. But the very, very important pillar of Ayushman Bharat is health and wellness centers, which actually focus on providing comprehensive primary health care, which means that you not only provide health services for communicable diseases or reproductive maternal child health, which our primary health system has done in the past, but more importantly, you also provide screening for non-communicable diseases, and you bring in an emphasis on prevention. So that has been one very important shift that we have seen in the health system over the last few years, and that's something that we will continue to work on. The second piece is on the prevention part, and there is a lot of focus on prevention, early detection, screening, and also the integration of Ayush. Because when it comes to prevention, then Ayush has a role to play there, and we've just celebrated Yoga Day yesterday. So there is also been a lot of focus now that we have tried to bring in on Ayush and how that links with public and preventive health. So that is another important dimension. Then, of course, when it comes to actual healthcare delivery, the focus of the government has been that health services should be available not just in the large metropolitan cities, but Also in the tier 2, tier 3 areas, that is also a focus of Ayushman Bharat, that we should partner with the private sector and increase penetration of health services in these underserved areas. And this is where technology can actually play a very big role as well. And during COVID, we saw a rapid acceleration in the adoption of technology. If you look at telemedicine, that is something that always existed. Telemedicine is not a new concept. But during COVID, we saw that its adoption went up very, very rapidly. Not just in the large cities, but even in some smaller cities and more remote areas. So we need to now use this momentum that we have gained during COVID and leverage technology to deliver access to health services, even in the underserved areas, even in areas where we do have shortages of health professionals. We have shortages of doctors and specialists, so we have to see how technology can come in there. And finally, I would just highlight that on human resources, a big focus of the government is on the human resources for health. The government has brought in many reforms in medical education, whether it's the National Medical Commission Bill or the Ayush Act, which was brought in. We're talking about nursing reforms. So human resources is a very, very important aspect as well, because in the health care ecosystem, physical infrastructure, as we know, is only half the battle. Without trained health professionals, we cannot really win the rest of the battle. So, and when we say trained health professionals, it's not just doctors and specialists. It's all cadres of health professionals, including public health professionals. It's very important that we increase the quality and quantity of public health professionals in the country. So that is, and I think just, finally, one other point is on medical devices and pharmaceuticals. That has been another very important focus area. And in fact, just recently, the new medical device policy has also been brought out by the government. And in both these sectors, there is a huge focus on making in India, that, we want to make as much of the medical devices, the drugs in India, but we of course want to do it with quality. And we also want to make the high-end devices. It's not just the low-end devices, but even devices which require higher levels of technology use. We ultimately want to be in a position where we are making those in India as well, rather than importing them from other countries. So these are just, I've just outlined some of the broad focus areas that the government, is looking at from the policy perspective, and I'll leave it to my panelists to, add more to this. Thank you.
Thank you, Urvashi ji. You have highlighted about the preventive health, capacity building, and various other areas which are the priority of government. Let me request Dr. Madan Gopal, advisor in the Public Health Administration, National Health System Resource Center, Ministry of Health, to highlight like some of the priorities and also some of the challenges which you like see as a healthcare ecosystem, and how collaboration between the government and the private sector and the startup ecosystem, in fact, maybe useful.
Thank you, Raviji. Thanks for this opportunity. You have rightly put this question, the opportunity of the startups and other things. You have seen that how health and economy of the country are closely related, and the COVID has proved it. When the economy was shut down, and you see what has happened, and we have to slowly revert back to that. And you look at the other way, hospital as an ecosystem for creating economical activities in particular area. You see, I have witnessed that during my working in the field for the last more than 30 years now. I have seen that if a hospital is created, whether it's a government hospital or private hospital, after 5 years down the line, you see a lot of economic activities are they have sprung around that hospital, and you see how the ecosystem develops around that. Second thing is, in the morning, the speakers have mentioned the major disruption which has happened in the medical field is the use of sensors and the biomarkers. They have changed the game. The technology is there, but the relationship between the patient and the doctor, that's a very sensitive. We can't, because in medical practice, patient doesn't read the book and come and present as a case. Whereas in the other areas, you can make a logic saying that 1 plus 1 is equal to 2. Whole of the body is comprised of lot of enzymes, chemicals and other than chemical. One biochemistry of one body is different than other biochemistry. You can't be having. That's why in medical parlance, we don't have averages. We only have ranges. That's the different. It's a lower range and the higher range. A person with 140/90, that would be normal for him. For other patient, it would be an hypertensive patient if he's not having that. So we have to see that how we address this thing. The digital ecosystem is there. One of the challenge, we have been talking that the digital thing will come and that will be the Jadoo ki Jadi and it will solve all the problems. No. We have to still go to the basics and see how the patient care is improved. That's still a challenge. The other challenge is how to use the technology. We have been always loading the technology into the health system, saying that if we talk about a program, the program is having a web portal and there would be subsequent 10-15 apps. Which app would be useful? We don't know. We have to create a mechanism for evaluating the technology which is there, which would be suitable and which can be used in the public system. That's one thing. That's why we have talked about, and to address this challenge, the Integrated Health Information Platform has come in, wherein all the other programs will be riding in, including it was before PMJ. It started in 2010-11 and now most of the programs are riding on that. This is about the complexities of the systems which are evolving during the last many years. But we all want to have robust data at our hand so that we can run the machine tools, AI, we can create algorithms, etc. To that, from where the data is being collected, that's the question which we need to ask. Otherwise, we would be landing up with a software which a very major tertiary level institution, they have outsourced it to this and they have to fight, because if the practice is not built into technology, the practice can't be changed with technology. That's the answer which we have to find. What will happen is, our data is collected by ASHA workers who are not that educated. They do have capacities, but their exposure to understanding of data is limited. We do have health workers, we do have persons who are entering the data at that level. We have to make technology which is enablement. Nobody has taught us how to use UPI apps. The technology has to build capacity into us. We have to see that if you are making any technology for data collection at that level, that should be so simple for that person. The complex things we can take care at the back end. But instead of that, we want all the composite, robust data should be collected by a person who is not having that exposure, who is not that educated also to handle such kind of thing, to understand the nuances of that data. We have to make the things simple at that level. I'm just citing one example from our, we all talked about that the health worker, female or male, were having so many registers. We try to simplify that thing. By way of simplification, what happens now, 40-50% of her time goes in data entry. So what she will do? That's the backbone of the extension of primary care services. That's there. That's one thing. That's a very serious challenge. How to address this? We have to see that we have to put our heads together and find a solution for that. To make life simple at the front end, the complex operations can happen at the back end. That's one thing. Second thing, use of technology. We should know how to use technology. We have been talking about blockchains and other things, but where to use it, how to use it, and who will be using that? That's the question we need to ask. That's the challenge. So much data is being generated during this COVID time. How many publications we are having? Where is the capacity to analyze the data? We have to, in this, that's the challenges. You have asked me to address challenges. These are the challenges. Where is the analysis? Are we only interested in doing the frequency analysis, making pie charts? Or we want to make some sense? Okay, what is the wait time? How to reduce the wait time? Not to talk about the patient quality. We want to, how to reduce the wait time. One of the challenges with the emergency medical ambulances is how to reduce the time of response to less than 20 minutes. We're still struggling with that. The ideal would be less than 10 minutes. So how to address that time? Here comes the data and other things. But the capacity to analyze this data is very, very limited. It is fashion to talk about big data, big analytics, but who is doing that? Where is the thing? Nobody is willing to share the data. In the PMJ example also, we cite the PMJ example. When the program was launched, we wanted to have the packages of the various programs, various packages. For that, some data was required. So if the data was shared, then the packages would have been more acceptable or more near to the ground realities. But whatever is there, if you look at the rates of CGHS, the CGHS rates are discovered. It is discovered by a mechanism by which the private providers itself, they say that for these procedures they would be charging this, and a median and other things is taken out. That procedure is there. But to arrive at what is a market thing, so we should know that what is the actual thing which is happening. So there is a disconnect between the actual the cost of the things and this. These are few of the challenges. The other challenge the COVID has posted, though the system has shown its resilience, is the infrastructure, investment into the infrastructure. Though we have the Ayushman Bharat program, which is having 4 pillars. One is Ayushman Bharat Health and Wellness Center. Previously, the strategy was primary healthcare. Now the strategy is comprehensive primary healthcare. That's why the erstwhile sub-health centers, they have been upgraded to provide 12 set of services. These are assured set of services which would be provided to health and wellness centers. Then the second is, after the primary care is provided, the secondary and tertiary would be provided by the Ayushman Bharat PMJ program. The second pillar of Ayushman Bharat is there. After the COVID times, we required that some infrastructure investments are also required. So the Ayushman Bharat and Health Infrastructure Mission was launched, basically to support and develop the infrastructure into the private sector. Then the other 4 pillar to connect all this, which would be overarching all this thing and would be overlapping in all these things, would be the Ayushman Bharat Digital Health Mission. Currently, the focus is on creating digital IDs as well as IDs for the institutions and seeing that how it is embedded into the electronic records. The other challenge is the provision of electronic records is there in the Clinical Establishment Act, which was enacted in 2010. At that time, the country has evolved some standards, and a snow-based CD license was taken as a blanket for the whole of the country. So that whatever information is, and all the institutions, all the states which have adopted that, they were mandated to have this electronic health records. And to codify that thing, snow-based CD license was there as a blanket to the country. And the challenge is that the uptake is only 11 states because we don't know what is happening in the other states. These are challenges. Before I close, another challenge is how to regulate the price of the procedures and the price and the quality of services. For a similar kind of services, one is charging 5,000 rupees, one is charging 30,000 or 1 lakh rupees. So, is there a change in quality? The same surgeon operating in that institution is charging 5,000. The same surgeon operating in a different institution charging this. The skills and other skill set and other things are the same. But where is the regulation aspect? So that's another challenge, that the regulatory capacities and the regulating the price and the market, that's another things. So these are a few of my thoughts. I will stop here.
Sure. I think Madanji has highlighted a range of challenges and which shows the complexity of the healthcare ecosystem in the country.
As both the speakers in the panel just mentioned, apart from the pure tech side, the legal part, like for example, Model Clinical Establishment Act has not been adopted by many states, including Maharashtra. So there are regulatory issues where the economics part, especially the variance, is no longer license Raj. So the private healthcare is not bound by anything to declare or seek permissions of government for declaring services. So this is again in the interest of only during COVID, for example, using the Epidemics Act, we were able to control the charges per bed, the regulatory framework for drug shortages, hoarding, supply chain shortages in oxygen and so on, ICU shortages. You know the whole story. So we need definitely better regulatory framework. Absolutely, I agree with Madanji. And the other part, I'm just sharing some of the things as previous speaker spoke. Maharashtra has done close to almost going to touch 3 crore proactive screening of women, right? So as part of the health and wellness, outreach, our government did close to 3 lakh women screening, including blood tests, where we discovered, precancerous growth in so many women, right? So we've gone to like pap smear, and we are gone now. We are going into treatment now. So we are doing, below 18 screening. So preventive health, it's a big game changer. Vision of the Honorable Prime Minister is stupendous in putting the focus into this preventive part. And the other great thing is telemedicine itself is going to bring down the cost on the economy. I mean, the loss of day's livelihood is huge. People coming there, waiting to see the doctor. Remote healthcare is going to bring down. It's going to save, so many millions of dollars in international terms of livelihood earnings, right? So, if we have better, healthier people, I mean, it's not for nothing. It's called the Ministry of Health. It's not the Ministry of Medicine. It's the Department of Health. It's not the Department of Medicine. So we are in the goal of improving the health of the country, and I want to just highlight one aspect, which is that of CSR. So in fact, Maharashtra has gone quite proactive, and we've got a lot of engagement with CSR. So this is the goal of public health. Is not just because there's public health, it's not like a public government health. So there is a bigger social movement, the CSR and the non-profit and international organization. I think we should all join hands together in this field, and we have started doing it. There's a lot of, that I feel is one of the ways to encourage innovation. I mean, I'm just sharing a methodology of how we work. If we find something extraordinarily good and our procurement process doesn't allow that, we definitely tell our CSR partners, like, look, they are just kids who have come up with fantastic ideas, great business models. It's not just, petri dish idea. It's a really workable thing. Then we have our partners in the CSR side who encourage, and we are able to engage with them meaningfully. So all of this put together, I think there's a larger picture of preventive, and as rightly said, I was just giving my comments on what is. I'm not picking up new topics. Training and manpower, paramedical and emergency care is very, very, very missing link in our system. They are highly burdened, and of course that has to be really reworked, including the syllabus for medical education, right? It's a lost cause in many cases. We are not linked to the industry or the demands of things. So people, I'm not going to name anything specific, but the syllabus of the education institutions also have to catch up and produce. Are we teaching doctors basic IT skills as part of MBBS? I don't know, right? Are we teaching IT skills to nursing schools? That is a business case. Be it a private or public, that's a business model for you. So we are looking at something like edX or Coursera for government. So we have started, I don't know, we may not know it. So we have started uploading courses which anybody in government can do, right? So we have started doing that. So a MOOC model, massive online thing, we are adopting MOOC model for government. So where courses are going to be put on, people can just sit in their phone and learn. So a lot of learning and knowledge management is also there. So these are some of my feedback, and with Raviji's as consent, I'll have to leave for a meeting. So I'm wishing the rest of the panel discussion the very best. Thank you so much.
Let me request our panelist Vikram Pagaria ji, who is the Joint Director at the Coordination, Private Integration and Capacity Building at the National Health Authority. So if you you have heard our other perspectives. So how you are seeing the role of ABDM and the NHA, and how they are like addressing those challenges in like some way, which have been highlighted by the other panelists.
Thank you. Thanks for the opportunity to speak at this. Just wanted to also inform everybody that National Health Authority is where I work is a very recently formed institution. It was formed in 2018 and it implements two schemes of the government of India. The Pradhan Mantri Jan Arogya Yojana, which is the insurance scheme providing a cover of 5 lakh rupees to around 40 crore people. And in 2021, it brought out the National Digital Health Mission, which is now called as the Ayushman Bharat Digital Mission, and which Madan Gopal sir rightly put it is among the four key components of the Ayushman Bharat scheme, and tries to create foundations for creating a digital health ecosystem, and also to provide standards. This is the broad mission of the Ayushman Bharat Digital Mission. What has been completed or what has been initiated in the past 2 years, I would just highlight as to what has been done to address some of the challenges that were mentioned. But I think the main intention, as Urvashi ma'am rightly put it, that we got to use technology. We in India would not be able to have doctors in all the villages of the country. In a country like the United States, in the remote areas, there would be doctors from Philippines, from India, from Pakistan, from China, who would work in their rural areas, and they would be able to provide treatment. But in a country like India, we might not be able to have such a situation. We got to use technology, and in the COVID era, we um, we could prove that yes, technology can indeed be used. I also believe that this time around 2020 to 2025 is a very important time, because when we think about the printing press, the Gutenberg press, it really revolutionized how information was disseminated. What I have written in one magazine could be printed 1,000, 10,000 times, and it could be disseminated to everybody. Uh, with the advent of smartphones, everybody can now use health services from these from their uh, from their rooms or from their houses, even if how remote it is. Um, the opportunities are huge. However, challenges are also huge. In a country like India, where we have 70% private care, uh, we were uh, we were having an internal discussion, and we found that around 2,500 EMR companies are there in India. We do not have any Epic or Cerner or five big EMR players who occupy a chunk of the market. It is very fragmented. Second is, um, another challenge is the demand side of it. In when we go to the public sector, I mean, Nawin Sona sir mentioned about the initiatives that Maharashtra has taken for procurement. But to be very honest, in my experience of the past uh, 13 years in the government of India, public procurement is an extremely difficult process. Uh, you all are budding private players. My advice uh, to you is that a lot of interactions you do with the government officials, you try and explain to them what your product is. But if you uh, uh, really want to excel, I think you should focus on private sector, because in public sector there are, if somebody comes and says that, oh, I have this pencil, and if you put your fingers over here, your ECG would be recorded. Or we have companies like Ognito. When I was coming, there is a stall which is just a side art stall. There are companies like Ognito which says that, oh, you speak on the phone, or you speak on the microphone, and your prescription would be typed. The capacity to utilize these innovations in the private sector is more than in the public sector. However, in the private sector, what I feel is that uh, the challenge is also in relation to uh, the cost of these software, to the cost of these products. Uh, when we look at laboratory management information software, we were finding that most of the laboratories give us digitized reports, but the software that they typically use is very, very rudimentary. They just do uh, a Microsoft Word kind of software, a software which is on the machine. It is not like cloud based, and a very fragmented towards billing and uh, rudimentary. So the demand to give money to various software companies is also not much. However, with time we would progress. Some of the interesting things that the National Health Authority is doing, and that might be of help to you, uh, is the emphasis on creating the foundations of this digital health ecosystem. Sir mentioned about our initiative to create health IDs, or the Ayushman Bharat health accounts for all the 140 crore uh, people of the country. Presently, we have been able to create around 40 crore IDs. Uh, and the emphasis is really that if you go to AIMS hospital and you say that, oh, doctor, I had gone to Apollo last month, and I also went to a rural hospital in Karnataka 2 months back, and the doctor in AIMS Delhi says, though, can you please tell me where, can you please show me the reports? And on the click of a button, or by providing an OTP, when the patient says yes, yeah, you can see my records, the doctor on her screen would be able to see your records. uh, because all records that are being created in the digital health ecosystem are being linked to the digital ID. And uh, and suppose, for example, you go to Apollo hospital, your laboratory report, or your diagnostic prescription, a diagnostic record, or your prescription is linked to your Aadhaar. And now suppose you go to AIMS Delhi, your prescription is also linked to Aadhaar. So when everything, all the records are linked to Aadhaar, then you would have a then you would create something which is called as the longitudinal health history. One of the very important factor that the National Health Authority has taken into account while implementing the mission is by taking care of the aspects of data privacy. Um, when we think of these records, uh, we be it created at Apollo, or at SRL, or at AIMS, or at the rural health hospital in Karnataka, all these records are lying there only. The government has no storage of these records. However, when somebody goes to AIMS Delhi, and suppose the patient says, yes, you can access my records of say SRL and Apollo, then only when the patient says, then the records come from these two places in real time to the doctor. Or if I have suppose a smartphone, I can click photos of all the prescriptions or all the records that are there in our houses, in our medical records, and I can push it to the doctor. Uh, Another very interesting thing that the National Health Authority is doing is to address the pain points of this entire healthcare delivery. Uh, One of the thing that we have started is called as the quick OPD registration service. So whenever, like some of you might be from Delhi, but all of you, if you would have visited a public hospital, there are huge lines. And if we come up, if we see this region around Ames, Delhi, you would see people standing as early as 4 o'clock in the morning to get their registration. What we have done is, given that everybody is now well versed with QR codes, everybody is using the UPI very easily, we have utilized this QR code. So what happens is that when you go to a public hospital, at the counter, you say, my name is Vikram Pagaria, my age is 36 years, my mobile number is this, my address is this, and then the receptionist at the counter, she asks, oh, what ailment you have, आज आपको किसको दिखाना है? तो आप बोलते हैं कि मेरे हड्डी में दर्द है, मुझे हड्डी वाले को दिखाना है. So what we have tried to do is, whenever a patient goes, there is a QR code, and if you scan the QR code from Aarogya Setu or from Abha or from any ABDM enabled app, then for example Paytm, Briefcase, Eka Care, so many apps are there. If you scan the QR code, all your details from your Abha card, for example your name, your age, your mobile number, your address, immediately goes to the counter, and you are given a token number 42, and your 42 number is displayed there. You can go and sit uh, at a comfortable place. Suppose when your number 42 goes, you you go to the counter and you say that, oh, I want to meet the orthopedic today, and the person immediately takes the OPD card and gives it to you. We have found that this has reduced the waiting time from uh, 40 minutes to around 5 to 10 minutes, and has been extremely convenient um, for old age people, or for pregnant ladies, and has able to address that pain points. Another initiative that is being done is that, suppose you go to a pharmacy and you say that, oh, uh, yeah, you scan the QR code, and you also have an option to push your record, or you take a photograph of the digital prescription, or the manual prescription, and you send it to the pharmacist. The pharmacist can see the record on her computer, and she can dispense the medicines. Um, these are some of the work that NHA is doing. We also have set up a stall here. Would like everybody to see, and there are my colleagues also who would be there, and happy to provide any more information that is there. Thank you.
Excellent. I think this he has talked about a situation, how a patient enters and how he interacts in the hospital, and how is this ABDM program which trying to simplify this whole process. So thanks for that. So we have heard the policy perspectives, the challenges, and we have heard some of the solutions which are being attempted, but we have to attempt hundred or thousands of more solutions to it. So we are delayed in the program, and I will request our panelists for a last round of interventions, and I will request Urvashi ji to speak about that. You heard Madan ji talking about a series of challenges which are there in the healthcare sector. So, what are the attempts by the policy think tanks like NITI Aayog? What are they thinking about the possible intervention for solutions on this?
Yeah, so I'll just, I think I listed all the priority areas previously. So, in fact, there's action on in all of those. And I think what we really need is, one, we need the public private partnerships to work for us and at scale, because, public private partnership is not new. We always talk about it, but we really need it to work at scale and in the underserved areas. That is where we need to take this partnership. Because, it's one thing to partner in a big city, but it's another thing to do it in a small, town or in a rural or remote area. So that is where we really need the public private partnerships to come in. That is where we also need technology to come in. Technology is not just about in big cities, you have big machines and scanners, and technology is about taking it to the through the smaller towns, remote rural areas where it's really needed. Where we have a real shortage of either human resource, or we have other challenges over there. So I think that is what we require, because policy action is on in all these different areas that I outlined earlier. But challenges obviously in the health sector are huge. We also need to increase funding towards research, and that's not just public but also private. We saw the COVID pandemic. We saw how much we had to invest in vaccines. But we don't need vaccines just for COVID. We need it for so many other conditions. We need adult vaccine for tuberculosis. We need so many vaccines to prevent and treat cancers. So we need funding to go into research, investment into research, new diagnostics, drugs, vaccines. This is something we urgently need, and this is again a very big area for public-private partnership. So I think those are some of the sort of thoughts in the end, I would say. And of course, two platforms like Elets and others, I would say that constantly keeping up this dialogue, raising awareness. The fact that you have done this summit here today, you have brought together different stakeholders. This is very important, because health is a sector where there is a lot of information asymmetry. A patient is always less aware, than the doctor or the health professional. So we really need to empower citizens. We need to make them aware about healthcare issues, and platforms like yours can play a very big role in that. So, that is something that I would also urge you to continue to do. Thank you.
Thank you, Urvashi ji. Thanks for highlighting the importance of conferences like this. And let me request Madan ji to give you closing remarks and talk about what are the possible solutions, because like challenges are massive, they are humongous. So where do we start, and how do we take it forward?
Raviji, one of the possible things, whatever we are doing, technology is an enablement that has been proven during the COVID times and in the coming times also. Whether this technology is bringing in the quality of services in the form of outcomes, and whether it is resulting in patient satisfaction, that would be the bottom line for any of the interventions which we do. At the end of the day, if the citizens or the patient, they are not satisfied and we are not able to provide quality of service, that's a challenge. A lot of efforts are going on. We are trying to reduce the disparity between the urban and the rural areas in the form of, it was done through NRHM, which was subsumed into National Health Mission. In the urban mission also, we are trying to address the disparities and the inequalities which are there. But technology is there. The technology mission we have started. The use of technology is there right from the village level to the national level. But whether it is resulting in any change in the practice, resulting in continuum of care, that we have done many screenings for your NCDs, that means the hypertension and diabetes. We have screened. We have put them on treatment. We know the number of treatment. But the longitudinal data and the other things, if it is available, and we are working in that direction. The other program which gives us a cohort to see, showcase and see whether our things are working or not, it was an aspirational district program. We have prioritized around 112 districts. The number would be more would be added to see that in a convergent way how we can uplift that places with the use of, because in that the networking is one of the key apart from health, education, the other aspects. The networking, the network connectivity is one of the important the things which is a part of that program. So lot of efforts are being made, but main thing is we are constrained by the capacities which are available beyond the tier 1 cities, tier 2 cities. The capacities which are there, they just you have only unilocular. Whatever you built in and building capacities of these people. We have tried the Aayog platform during this COVID time. We are using the technology for training these people, but after the training, follow-up, hand-holding, the supervision aspect, the work is in progress in that direction, but plenty of things to be done. So that's the only thing which I can say. At the end of the day, for whom we are working, they should be satisfied. If they are not happy, then the whole efforts and other things would be all details, and we are only discussing that.
Thank you. I think you talked about the patient focus, the focus on the exact remedy itself and the patient. Requesting Pagaria ji for your closing remarks.
I think we had a good discussion. I would just request all the private players to identify the exact pain points in the digital healthcare delivery, try to address them, try to, like the scan and share example I gave, there is an immense need of what you say, of repairing the digital health ecosystem or the health ecosystem. There are loopholes or holes everywhere, and as a plumber, one has to repair, and it is the private and the public sector both who would be able to do that. The public health sector or the digital health sector also has a challenge wherein, as compared to the financial technologies, the fintech sector, is that when UPI had come, the banking sector was digitized. Everybody was doing internet banking. When we think of the corresponding scenario in the health ecosystem, if you see public hospitals, there is a shortage of hardware, internet connectivity, persons who understand the software, how to use those software. So, and also in the private ecosystem, as I had shared, in the private hospitals, doctors are very wary of using these digital health software. Whenever I interact with some of the companies like you, I am reminded that उनको ये लगता है कि हमारा इनकम टैक्स का मामला पता चल जाएगा, because as soon as I try to come on digital prescription, or I write digital prescriptions, I would the number of patients I see would be detected, or I would end up in medical legal cases. So these are all challenges that we have to address. But the good part also is that our system is not as rigid as the US healthcare system. In the US healthcare system, when this digitization or interoperability was brought, there was a lot of resistance because things were already set, and to change anything becomes difficult. If we are able to bring about an innovation like the UPI in the fintech sector, if you transfer some money from a US bank account to a US bank account, it takes 3 days. First I will enter the bank account, then they will deposit $0.02, and then they will confirm whether $0.02 has been reserved, and then the transfer happens. And here it happens in less than 3 seconds. So the fact is that we have an advantage we have a fertile soil. All we have to all we have to do is make efforts. For you, my advice would be to be open-minded and try and address the pain points. That's it. Thank you.
Thank you. And I think the next big agenda is to actually find that UPI of the healthcare sector. So thanks for highlighting this.